I am Valentin Fuster from New York, and we are in Madrid today, the European Society of Cardiology meeting. It's the 75th anniversary of the European Society of Cardiology. Well, I'm very happy to be discussing some of the trials presented in this meeting, as we usually do, and I am always surrounded by talented people who actually help me in making, perhaps, conclusions of these trials. I'd like to introduce my colleagues today, and I will begin with my left. Dr. Roxana Mehran is Professor of Medical Population Health Science and Policy at the Mount Sinai Medical Center in New York. She's the Director of Interventional Research or Cardiovascular Research and Clinical Trials, also at Mount Sinai. She's the Director of the Women's Heart and Vascular Center, and she's the upcoming President of the American College of Cardiology. Thank you for being here with us, Roxana.
Thank you, Dr. Fuster.
Dr. Gry Dahle, a surgeon. She has been with us before. She always do well. She tells us, all the medical-oriented people, when we are right or wrong. She's from the Department of Cardiothoracic and Vascular Surgery at the Rikshospitalet in Oslo, Norway, and Director of the International Society for Minimally Invasive Cardiothoracic Surgery. Thanks again for being with us. Oh, here's my friend, Dr. Kalyanam Shivkumar. I know him forever. Mm-hmm. Why? Because I was the editor of JACC, and he continues to be the editor-in-chief of JACC Clinical Electrophysiology. He's Professor of Medicine at the University of California, Los Angeles, and thank you very much again, Shiv, for being with us.
Thank you so much, Dr. Fuster.
And finally, another person that I know well, Biykem Bozkurt. Why I know her so well? Because she's another editor-in-chief of JACC Heart Failure, and we worked together for many years. Biykem is Senior Dean of Faculty, Director of the Winter Center of Heart Failure at Baylor College of Medicine in Houston. And thank you for being with us again. You have been here for several times.
Thank you, Dr. Fuster.
Well, you know these people, so we don't have a problem in having controversies with people who are quite talented and have a lot of judgment. What we are going to do? Well, if you go over the breaking trials in this meeting, there were 41. I decided to choose 9 to be discussed, and if we have time, I have comments about 4 or 5 more. What these trials are, the 9 that we are going to discuss, well, 2 are on atrial fibrillation, 3 are on myocardial infarction and beta blockers. There are 3 in coronary artery disease, and there is 1 in hypertrophic cardiomyopathy. So let's go to work. Let's start with atrial fibrillation. And the first article we are going to be discussing is the Alone AF Investigators study. The actual title as it was presented is Long-Term Anticoagulation Discontinuation After Catheter Ablation for Atrial Fibrillation, the Alone AF Randomized Clinical Trial, presented by Dr. Deborah Kim from Seoul, and the paper actually has been submitted to JAMA. Let's see what the question is. We have many patients with atrial fibrillation and undergo ablation. And the question is, for how long you keep anticoagulants? And I will tell you, there is no consensus, even if you go to guidelines, because the patients may be at high risk for thromboembolism, at low risk. Anyway, this paper is addressing this issue. So the Alone AF trial is in patients with atrial fibrillation that was designed to evaluate whether discontinuation of oral anticoagulants could lead to fewer adverse events, including a stroke, systemic embolism, and mesh bleeding, compared with direct oral anticoagulant therapy in patients without documented atrial fibrillation recurrence for at least 12 months. My understanding, Ship, is that the patients for 12 months didn't have atrial fibrillation, and then is the moment that anticoagulants are stopped in a randomized fashion. Is this correct?
The way they designed it,
Yeah.
that's the approach.
So we'll discuss this in a moment. So now let's go more into the details of the study. This was an investigator-initiated, multi-center, open-label, randomized trial involving 18 hospitals in Korea. A total of 840 patients aged 19 to 80 years who had at least one non-gender stroke risk factor as determined by the CHADS-BASC, and no documented recurrence of atrial fibrillation for at least 12 months post-ablation. And they were enrolled in a randomized fashion to be continued on anticoagulants, or anticoagulants were stopped. What were the primary endpoint? Well, before let's discuss what anticoagulants were used. Actually, apixaban, 5 milligrams twice daily, or rivaroxaban for about 20 milligrams daily, and if the patient had reached the dose, were decreased. Now, the primary endpoint is important. Stroke, systemic embolism, and mesh bleeding at 24 months. A total of 417 patients were assigned to receive no oral anticoagulants, and 423 to receive oral anticoagulants, which is continuation. The CHADS-BASC score is of interest because it was only 2.1. So I'm saying this because these are not patients I would consider at high risk for thromboembolism. At 24 months, we have the data here. The group on no anticoagulants, 0.3% events, the primary event type. In the other group, on anticoagulants, actually 2.2%, a little bit the opposite of what you would expect. But the rate is very, very low. The observed cumulative incidence of ischemic stroke or systemic embolism was similar in both groups. And mesh bleeding was very low, actually. It was in 0 patients in the anticoagulant group and 1.4% in the anticoagulant group. Well, here are the conclusions. Among atrial fibrillation patients with no documented recurrence of atrial fibrillation after catheter ablation, no oral anticoagulation treatment resulted in a low risk of composite of a stroke, systemic embolism, or mesh bleeding than patients that were treated with anticoagulants. Well, the question that I have, and I am asking you because Chip, you have been involved with all of this, is that these patients are at a low risk. So if I have a patient with a CHADS-BASC of 4, 5, or 6, would discontinue anticoagulants at 1 year? Before you answer this question, tell us about the study. What is your reaction?
Thank you for that, Dr. Fuster. I think in all the cardiologists in the world would tell you that the approach for even catheter ablation of atrial fibrillation is symptoms of the arrhythmia itself. And if you ask patients what is their biggest issue with quality of life, the second highest priority a patient has is the use of anticoagulants. So, and it turns out the way we have looked at this is how a cardiologist would look at it, and that is the overall composite risk of stroke. And I would actually start off with what has guided our practice and perhaps the whole field is the great editorial that you and Jim Chesebro wrote in the 90s, which is atrial fibrillation should be seen as a risk marker for stroke and not a cause of stroke. So that is our overall approach of how we approach the patient. So at the outset, I'd like to say that the risk of thromboembolism is highly determined by all the coexistent conditions, and the patient should be looked at holistically. So, with that caveat, this study is looking at a group of patients in whom most people in practice would be comfortable not anticoagulating the patient. Okay. So it sort of completes the story, but it's not dramatically changing pre-existing practice, at least in academic centers.
I have a question though, following. Okay, I have a patient with a CHADS-BASC of 2, and now I have a patient with a CHADS-BASC of 7. Both have ablation, no recurrence of atrial fibrillation in the first year, what would you do?
I fully agree with you, Dr. Fuster. CHA2DS2-VASc score of 7 would compel me to continue or consider continuation of the anticoagulation. As Shiv said, it's holistically the risk, the underlying risk.
Yeah.
So what resulted in that high risk? If you were to add heart failure to that, I certainly will be continuing
Absolutely.
it. So it's the LV, the structure, as well as the comorbidities, the age of the patient.
Well, we are in agreement, actually.
Absolutely.
Roxana, you have any comments?
Yeah, I'm in agreement with everything you just said, but what I'm nervous about is with 800 patients and such a low event rate, to be so sure that this is a definitive answer. You would need much larger numbers of patients for a longer period of time.
Yeah, I tend to
But
agree.
with a low CHA2DS2-VASc score, I think you're in a good safe space.
Yeah, this is a low score,
Yeah.
you know, and that's it.
So I'm not
Hey,
sure.
What do you think?
I think it's safe to do it in a low CHA2DS2-VASc score, but you know, if the CHA2DS2-VASc score is high, why not close the appendage?
Yeah. Well, I think it's interesting. One thing I can say, though, if the patient has a score of 2 and has recurrent atrial fibrillation in the first year, you agree the patient should continue on anticoagulants.
Absolutely.
Yeah. Well, it seems to me that we are all in agreement with this study. Well, now let's move into the second on atrial fibrillation and see if we are continuing to be in agreement or in disagreement. For a long time, I think for the last 4 or 5 years, I see article after article, and that is you look at your watch every morning and you look at, oh, atrial fibrillation, I am in big trouble, anticoagulants and so forth. Well, this is the question. The question is, should we do some kind of testing ourselves, maybe with your watch, if you are having atrial fibrillation or not, and if you have atrial fibrillation, then to go into the anticoagulation. This is the paper, actually, and it's an interesting paper because it's a large number of patients, so-called AMALFI study. The title, Remote Screening to Asymptomatic Atrial Fibrillation, the AMALET Randomized Clinical Trial, the AMALFI Randomized Clinical Trial. Well, it is interesting. This paper comes from the group in Oxford and was presented by Dr. Bowman. And the question is very simple. Basically, you have a group of patients, or the individuals, who are at relatively high risk. And then what you do is you put a device and you look for atrial fibrillation in the first 2 weeks. And then if you have atrial fibrillation, what about a couple of years later? Are you going to have atrial fibrillation again? Compared with a group that you do nothing, and 2.5 years later, do you have atrial fibrillation? So you are comparing a group that you are obsessive about it with a group that you are not obsessive at all. That's the study. Well, let's now go into the details of the study. This is a randomized controlled trial recruiting from 27 UK primary care practices. The study ran from May 2019 to February of 2022. All eligible individuals aged more than 65 years with a CHA2DS2-VASc which was equal or more than 3 or 4, 3 men, 4 women. So this is the risk was a little bit higher than on the previous study. With no previous history of atrial fibrillation or flutter were identified via automated electronic health record. Of the 22,000 individuals that were invited, 22% accepted. We see about over 5,000. They were randomized in the way I presented. One group for 14 days, continuous monitoring, and the other group nothing. And the question is, what happened 2.5 years later? And actually, to go straight to the answer, nothing much. Actually, 4.2% atrial fibrillation clinically developed in the group that actually was monitored versus 6.8% in the group that was monitored versus 5.4% on the other. Now, this is interesting because of these 5,000 people, half of them that were monitored, the atrial fibrillation that was detected was only in 4%. despite of a relatively high risk for atrial fibrillation. But at the end of 2.5 years, no difference whether you were monitored or you were not. I would say this is a study of a number of studies showing the same thing, and that is we are very hyper in knowing who's going to have atrial fibrillation, but at the very end, you achieve very little. And I don't present data on anticoagulants. You know, the group that were monitored who had atrial fibrillation were on anticoagulants. The other group, some were, some not, and there was no much difference. So here are the conclusions. Male-based AF screening, because they returned the patch, the EKG patch by mail, of older patients more than age 65 at moderate to high stroke risk led to a modest long-term increase in atrial fibrillation diagnosis at 2.5 years if you were monitored. Well, Roxana, what do you think? Are you going to monitor yourself when you are over age of 65? And if you have a little bit of a risk?
I like monitoring my patients, but I don't think that this particular study gives us any kind of a clue of what is exactly to do.
Why you
I'm
like
not
monitoring?
surprised.
Why you like monitoring?
I especially if they have symptoms, I absolutely monitor them, because if there's symptoms associated with it, as we just heard, I would think about ablation and bringing them to ablative therapies. And I'm not surprised about these results. And 14 days of monitoring may or may not be enough to be able to capture what you get. And that moderate increase, again, it's numerically higher a little bit, but doesn't meet the statistical significance.
Okay.
Watch is a different story though, right? I mean, these are patches. A watch is something that one wears all the time. And I have a lot of patients who come in with those symptoms. So that's a different one I'd like to see.
You agree with everything she said?
Fundamentally, yes, Dr. Fuster. And the interesting challenge that we see is the more you monitor, the more you see. And we are now left at a point of time where historical studies didn't have this standard of monitoring. So I would again state that the first, second, and third aim of treating atrial fibrillation is to prevent a stroke. Therefore, I think these are stepping stones to what would be more meaningful studies when we get more data. Now, is this a variable like other powerful cardiovascular variables like hypertension, for instance? That is something which the larger field of cardiology, where clinical trialists and people like you could guide us with. But I'm still a big fan of trying to find out more. And we shouldn't, because with AI, with all the technologies, whether we like it or not, these are over the counter. People are going to monitor themselves and come to us. So we need to inform ourselves.
Biykem, you have two people here that they monitor themselves constantly. What about you?
I see it as the following. Yes, this study is not practice changing. I do agree. And I think having stroke as the outcome of these trials probably is limiting our scope. I see it as a potential for prevention, because I see AFib as a sign of start of the failure, the cardiac failure. And in essence, it's a maladaptive process of some sort that is starting to show us the signs. And I think in the future, that's going to be a screening by which we're going to start preventive measures as well as prevention of stroke measures. So if we could prevent the progression of heart failure in that pre-stage, that would be wonderful. And I think we should have outcomes in that regards.
Well, I think in part I agree with you, but before I make a comment, I will ask Gry, what do you think? Are you monitoring yourself?
No, but I love wearables, and I think it's important that people do it. But the kind of the obstacle is that if people monitor themselves and they find out something and they don't know what to do about it, so then they get nervous maybe. So it's a good thing to monitor, a good thing to discover, but we have to kind of calculate the risk of making people nervous and making people do some things that they don't know what to do about.
I understand all of you, but I see things a little bit more conservative, I certainly monitor people who I think present by the history with something that could smell like atrial fibrillation. But if you go to the overall population, you start monitoring, I think it's going to be, at least at this time, maybe we need to know more about it. I think the study is interesting, but at least personally, I still feel that I would like to monitor people who I just have a feeling they have atrial fibrillation, or they present with a history of atrial fibrillation. Well, anyway, it's an interesting study with a large number of people, you know, but this is the story. So a number of other studies show the same thing. There is something there, but still we need more time to decide what do we do. Well, this is atrial fibrillation. Now, Shib, you can rest for a while. Well, not really. There's no rest for anybody here.
Beta blockers.
Exactly. Now we are going to have 3 papers on beta blockers. First of all, I will try not to be biased, but I have been involved with these studies. In fact, the first study that we are going to be presenting is the REBOOT-CNIC study. Beta blockers after myocardial infarction without reduced ejection fraction. This study actually will tell how it evolved. It evolved because I was in Edinburgh when Desmond Julian actually did the study with beta blockers. And the first beta blocker, if I recall, was atenolol. And this was following myocardial infarction. The study was in favor of atenolol at that time. And I remember the excitement, and year after year. But you know, then you begin to open the artery with myocardial infarction. You begin to use all the drugs that we use, the aspirins, the ACE inhibitors, and so forth. And frankly, I became maybe skeptical that patients with normal ejection fraction following myocardial infarction should be treated with beta blockers, despite that the AHA-ACC guidelines and the European guidelines is you should treat everybody with beta blockers. So I talked to Borja Ibanez in the CNIC and says, you know what, let's do the study. And this is actually how the study actually developed. And we were able to convince a number of institutions in Spain and in Italy. I think we're about more than 100 institutions to really participate in the study. And these actually are the details. We conducted a prospective randomized open-blinded study at 109 centers across Spain and Italy to evaluate the effect of beta blocker therapy compared with no beta blocker therapy among patients with acute myocardial infarction with or without ST segment elevation in a left ventricular function that was either 40 to 49% or 50% and higher. So it was a preserved ejection fraction, mildly preserved in one group. The primary outcome was a composite of all-cause mortality, reinfarction, or heart failure hospitalization. Were 8,000 patients that actually were randomized beta blockers versus no beta blockers. Actually, the beta blocker used was the physician decided which beta blocker to be used. In the other group, beta blockers were not used. This was an intention to treat analysis. And what the follow-up, I believe, was about 3 years, 3.7 years. Well, the results actually, I would say, were very, very similar in both groups. 22.5 per 1,000 patient years in the group that, in the beta blocker group, and the other was 21.7, no difference at all. All-cause mortality, the same, practically the same. And then we look at non-fatal reinfarction, 10.2 versus 10.1 per 1,000 patients. I want to emphasize the event rate. The event rate actually on the primary endpoint is actually 1.1 versus 1.2 per 100. I want to emphasize this because the incidence rate was very low. So the patients were not very sick for whatever reason. There were no apparent differences in safety endpoints between the groups. And then what we have here is the conclusion. Among patients discharged after myocardial infarction, managed invasively and with a left ventricular ejection fraction above 40%, beta blocker therapy showed no evidence of an effect on the incidence of the composite outcome of all-cause death, reinfarction, or heart failure admission. I would say that the group of patients between 40 and 49% was small, so very difficult to do statistical analysis in the two groups separately, so it were taken all together. I think that maybe before we go any further, let me present the other study, Norway, Denmark, and Finland, isn't it?
No, I don't.
And this is the beta blocker after myocardial infarction, also in patients without heart failure. This is the BETAMI-DANBLOCK study. It actually are two studies put together. I'll go into the details and then we'll compare both studies. This is an open label randomized trial with blinded endpoint evaluation. This was also in the first study, conducted in Denmark and Norway. Left patients had left ventricular ejection fraction, same in the other study, above 40 or 40% or above. And they received long-term beta blocker therapy within 40 days of infarction or no beta blocker therapy. The primary endpoint was exactly the same. It's the composite of death from any cause or measure adverse cardiovascular events. The cardiovascular events here, in the other study was heart failure. Here is a number of things, heart failure, ischemic stroke, reinfarction, and so forth. So it was a little bit more open, the primary endpoint. What is interesting is the results here. The results are in the primary endpoint that I mentioned, 16.3%, 14.2%, so the event rate is completely different. We'll discuss why, but although the primary endpoint is larger, but when you look specifically the same primary endpoint in both studies, there's a significant difference in the terms of events. And then the results are 16% versus 14%, so it's close. When you look at all the endpoints independently, there is no significant difference in any one, so you have to put all together. The conclusions are the opposite to the previous study. And they say among patients with a myocardial infarction in a left ventricular ejection fraction of at least 40%, beta blocker therapy led to a lower risk of death or minor adverse cardiovascular events than non-beta blocker therapy. So these are the studies. I don't want to make any comment because I participated on the first one, but this is open. Biykem, what do you think?
I think the mildly reduced EF proportion is the key. And there's a little bit of a difference between the proportion. I think in the REBOOT, it's lesser than the other study. And the second concept is, as you alluded to, is the Denmark study has the MACE endpoints, the revascularization, as well as stroke, as well as heart failure, MI, and death. Therefore, the other components are raising the event rate. And some components of that, especially the reinfarction in the other study, was a little bit less. And maybe the regimentation of the beta blockade in the Denmark study may have made a difference, though that's just a hypothesis. I think the key is the proportion of patients with mildly reduced EF, which I think was higher than the REBOOT study.
Yeah. Thank you. What do you think?
It's fascinating, Dr. Fuster. For me, I'll wear my hat as a physician scientist. What I need the most when I see patients who've had any form of cardiac injury is to see how much their neuroendocrine activation starts. And I often wonder, how you make that decision. And I think we've always defaulted to the safety of using a beta blocker versus not. And is the timing of the infarction, did it play a role? I would be curious to see what the panel and someone like you would look at it. A remote injury event versus someone who's more in the remodeling phase of their injury.
Thank you. Roxana.
So I love testing or challenging the status quo. And I congratulate you for doing that in Spain, in all of these centers. And I think it's really important because withdrawing therapy is a good thing. Many patients are on multiple medications that they actually do not need. And I think I fully agree with Biykem. I think the idea, these are different populations, and perhaps with the current revascularization, early revascularization, great treatment of patients with STEMI and non-STEMI, that these patients preserved their ejection fraction, did well, and didn't need beta blockers. So I actually believe your study, and I think we overuse beta blockers and make patients miserable, and maybe even increase, you know, their hemoglobin A1C and other things that goes along with it. So in the Denmark study, I agree. I fully agree. It's the mildly reduced EF, broader endpoints, higher event rates.
Thank you. Gry, I have a question. Why the event rate, you come from that part of the world, why the event rate is much higher here than in the Mediterranean countries? And let me say that the endpoint is larger, but even if you actually what I did is I look at the same endpoint in both studies, still the incidence rate of events is much higher in Denmark and than in the Mediterranean. In this study, is this in real life too?
Well, maybe. It depends on the revascularization request, because in the Norway study, or Norway and Denmark, it was a demand that the patients had to be revascularized in Norway. In Denmark, it was not a request. I don't know, in the Spanish study, it was not a request to be revascularized or not. And we have also studies in the Nordics looking at the surgical revascularization, and there we always use beta blockers to stabilize, to kind of avoid arrhythmias. So I don't, maybe there's some genetic difference, and so I think the event rate, I think it's
well,
you know what I think, Dr. Fuster?
Yeah.
I think that in the Nordic countries, they have these amazing registries. So every patient who goes anytime, they capture every event. Very, very different than other places. And they could very well be that that's how we get more events.
I think this is a good point. Well, actually, one of the issues is we decided actually, and we co-participated, both groups, in two meta-analyses actually. The first meta-analysis was presented in the Lancet, which is to take these two studies and two more and to look at the mild ejection fraction. With, you know, the mildly decreased 42, 49%. And just to make the long story short, it was a significant difference in favor of using beta blockers when there is a 40 to 49%. We again, in our study, we didn't have the statistical power when you put all the studies together. And now what we are doing a meta-analysis of more than 50% ejection fraction also, just to be sure that the feeling, the overall feeling among all of us who, the two different studies is that, and I think you mentioned, you took when the ejection fraction is more than 50%, probably you can have you can avoid taking beta blockers, which is in about 40% of the population post-MI. And if the ejection fraction is between 40% and 49%, you still use beta blockers. So that's basically the consensus.
But Dr. Fuster, can I just make a question about the female participants? There were only 20% female in both studies. It's very strange.
Female, you say. Well, you know, I was going to make a comment at the very end about this.
Okay.
Because
sorry.
We study that aspect, but I leave this for the very end, okay? So at this moment, let's follow the pattern that we decided, because in 1 hour you cannot do everything. But I think we are doing very well, by the way. Well, so we have done 5 studies, 2 on atrial fibrillation, and 3 studies on beta blockers. And now we get into coronary artery disease. Yeah. The first study, I frankly, I find the study a little bit complex, but let's try to simplify. Is the OPTION-STEMI study. Was published in the Lancet at the same time that being presented immediate versus stage complete revascularization during index admission in patients with ST segment elevation, myocardial infarction, and multivessel disease, a multi-center non-inferiority open label randomized study. First of all, I don't know if you agree or not, but what I learned all these years about all of this is if a patient is multivessel disease and is not in shock, you have two options. One is to do the culprit lesion and all the other lesions that you consider are significant, or two, when the patient is discharged, and we do the so-called staging. But the patient is discharged. Here, the interesting issue is the patient is not discharged. So the decision is made at the time that the patient is in hospital. This is what is different about this study. And we can go actually into the detail, but I find a little bit complex the way it's presented, but I will tell you the results. Very basically, what they find is that during hospitalization, if the patient actually is just do complete revascularization from the beginning, and then the other you do is staging, so you wait for 3-4 days, there is non-inferiority. The patients who do staging do better. That's basically the point. And the question is, these patients that do better are specifically on KILIP 2, 3, or 4. In other words, they have a little bit of heart failure. This is the group. Now, the question is, when a patient comes to me today, what I do with everything I learned in the past, and I was going in circles, Biykem, what I would do. You know, if the patient is absolutely post-MI and no heart failure, it looks one of those that everything is going fine, you know, to do just aggressive approach in the hospital versus an approach after leaving the hospital, there is no much difference, so I would be relaxed. If a patient has a little bit of heart failure, then I would be very careful here. And if I have to do something, I wouldn't do the aggressive approach at the beginning. I would stage either at the time of the hospitalization or after. I am only telling you the summary of something that's pretty complex, but I'd like to hear from you.
I do agree with you. If after the culprit lesion, the patient is still showing signs of LV dysfunction along with heart failure symptoms, we tend to look at the other lesions, trying to do a complete revascularization earlier meaning before discharge. And I think that's similar to what we do in practice. We don't usually like seeing heart failure post-MI.
Yeah.
And either we want to see resolution of the heart failure at the time of discharge, and if they are still showing signs of heart failure, we look at everything, including ischemia and or other complications. Yeah. And the thing that is not done in this study is late post-discharge revascularization versus, so that's the concept.
This is the complexity.
Answer. Yes. I'm not so sure I would do all vessels. Yeah. Maybe I will do the culprit and then the other one that looks bad because then we need to spare the kidneys. Yeah. It's always a risk-benefit. Yeah. So sometimes I think individualization according to the presentation. Yeah. And of course, not every multivessel disease is PCI. It could be also bypass or heart failure.
They did FFR in those patients with stenotic lesions between 50 and 60% and so forth. Well, Gry, what do you think about all of this? This is not easy, but certainly we open all the arteries sooner or later, but it's a little bit complex because the study is only during hospitalization.
Yeah, but this is a surgical thinking. If you operate all the lesions, and if you don't, and if you do PCI, you can do it staged, and I think that's reasonable. So I agree with actually with everybody. So it's the individual thing to look at each patient separately and then find a solution for this patient. What is best? Is it best to do the culprit lesion for this patient because he's a kidney failure? Maybe you can wait and if he hasn't any angina or anything after that, you can just leave it. Or if he make symptoms of angina or heart failure, then you do it. But you can also consider surgery.
It's a lot of judgment, isn't it?
Yeah.
An individual patient. What do you think, Roxana?
It is all about judgment, actually, and this is a really actually very important question. Believe it or not, we as interventionalists are always faced, we know that we should do complete revascularization. The question is immediately at the time of STEMI or within the hospitalization. That's a very, very valid question. And I've always, because I care about AKI, I've often say, if the other lesion is complex, let's say you have a right coronary lesion and you put a quick stent in, but now the LAD is calcified, bifurcation, and do I approach it right now in the throes of a STEMI? I want to wait a couple of days. I want to see how the patient does. If they have chronic kidney disease, diabetes, I want to see if the dye was, I don't want to be giving them more dye and dealing with a calcified rotoblader bifurcation LAD now in the setting of a STEMI. So I think it's all about judgment and personalized medicine. The truth is we have to do complete revascularization, and as the COMPLETE trial tells us, and it seems like if we could do it, the earlier the better, because leaving patients with proximal lesions that are tight in non-culprit vessels is not a good option. Even waiting 30 days could have an important negative impact.
I have a question following you, Biykem. We are all talking about complete revascularization. The question is judgment, when?
Yes.
But are you avoiding it only in shock, or you are avoiding when the heart failure is significant? I mean, this is the next question.
Absolutely. Yes. I think in shock we've had some controversial findings. So shock aside, for other patients, yes, complete. As Roxana said, I do agree not going after a lesion that is so complicated that's going to create an on-the-table catastrophic circumstance post-MI complicated with heart failure. But at the same time, on the other side, I don't want to leave this patient unattended without a complete revascularization. But fully agree with Roxana's comments about it's all about personalized, and it's all about a partnership with all our colleagues, with surgeons. So in heart failure, it's critical.
Thank you. Well, it seems we are in agreement on too many things. Let's see about aspirin, and perhaps we'll be some disagreements. Okay, we have 2 studies on aspirin in acute coronary syndromes. And let's begin with the first one, I think is from Brazil. The study is called NEO-MINDSET study. The title is Early Withdrawal of Aspirin After PCI in Acute Coronary Syndromes. This was presented in the New England Journal of Medicine. Let me tell this story, and maybe Roxana, you can perhaps be in agreement or disagreement. It seems to me that the way it all started, and actually we were very involved with the use of rapamycin. It all started that patients with coronary artery disease following infarct, it was a problem of the type of intervention. Restenosis was very high. And then it came the drug-eluting stents. With the drug-eluting stents, what happened, the restenotic phenomena dropped, but still the thrombotic phenomena predominated. And then we used the dual antiplatelet therapy. I mean, that's the way. Then comes the second generation of drug-eluting stents. The second generation of drug-eluting stents says, there's not so much thrombosis. Why you don't start cutting one of the drugs, one of the platelet inhibitors, and at least relatively speaking, we might have less bleeding. And then this story is fascinating to me because I have followed this in your studies. It seems to me it all started, well, at 6 months, let's stop aspirin. At 3 months, let's stop aspirin. And now, at 1 month, let's stop aspirin. And here the studies, you stop aspirin at day number 4. So this is the story as I see it. Now, the question is what happened when you stop aspirin the day number 4 after a myocardial infarction? It doesn't look good. Is that right? Let me go into the study. The study is, we conducted a multi-center, open-label, randomized trial in Brazil. involving patients with acute myocardial infarction who had undergone successful PCI. The first 4 days of hospitalization, in one group, aspirin was stopped, and in the other group, they received aspirin and a P2Y12 inhibitor and ticagrelor or prasugrel. So there are 2 different groups here, one monotherapy from day number 4 and the other dual therapy. And then they use a little bit of a non-inferiority for the endpoint, which was the composite of death from any cause, myocardial infarction, stroke, or urgent target revascularization. And then they use superiority in terms of bleeding. Well, obviously less bleeding with monotherapy than with multiple therapy. Well, here are the results. The results is that actually the issue of was troublesome in the group that they discontinue aspirin, with the event rate 7.7% versus 5.5%, the highest in the aspirin group, in the group that was discontinue aspirin. And then what was very troublesome is actually the problem of thrombosis of the stent. 12 patients in the group that monotherapy versus the 4 patients in the group with dual antiplatelet agents. And then the bleeding was 2% in the group with monotherapy versus 4.9% in the group, the dual antiplatelet therapy. All of these you have to read very, very carefully, but the bottom line is actually the conclusions of what I said, and that is among patients who had undergone successful PCI for acute coronary syndromes, potent P2Y12 inhibitor monotherapy was not found to be non-inferior to dual antiplatelet therapy with respect to a composite of death or ischemia events at 12 months. So the question here is, it was wrong the thinking that the first few days is not a problem with thrombosis. That's the way I see it, and it's a problem. How do you react to the study?
Yeah, I have to say, you know, I was not surprised with such an early withdrawal, but I was hopeful that it might be that we could withdraw aspirin even earlier. Because as you know, in the double-blind placebo-controlled trial that we ran with Twilight, we gave a 3-month, because those first 3 months are just studded with ischemic events. And then we withdrew. Then there were other investigators who shortened it down to a month. And then the question was, can we stop even earlier? And a lot of it had to do with the work of you and Badamon in the chamber work that we did, looking for blood thrombogenicity in absence of aspirin with ticagrelor on board in these patients. And it showed that there was no increased blood thrombogenicity if you could get the ticagrelor on board for a good period of time. In those early days post-MI, I am certain these patients' ticagrelor was not fully absorbed, not fully functional, so that the aspirin was needed. Maybe they needed it for 2 weeks, maybe for a month, but you should not withdraw it immediately. And we often, as you know already, the moment patients come in, whether they're on aspirin or not, we give them a loading dose of aspirin to start chewing on so that they can really absorb and get the antiplatelet regimen. I was hoping that it was going to work, but it doesn't. Not in that first, such a quick withdrawal of aspirin we're not ready for. But let us make sure that we do not misinterpret this, that all the prior studies and the new class 1A indication of ticagrelor monotherapy is now nullified with this small study. Small because it's only 3,000 patients. The endpoint is, as you know, we studied 9,000 patients with a hard endpoint that showed no difference. So
it's interesting, Gray. We did the first study on aspirin saphenous vein grafting.
Yes.
And actually, we gave the aspirin chewing because what we saw in the doc when we did bypass, the thrombosis took place very early in bypass grafts in the first 48 hours. So we were always concerned, and then at the very end, you give the aspirin early post-op, not necessarily chewing the aspirin, but certainly these first few hours are very troublesome in somehow. How do you view this issue, aspirin being withdrawn within the first 4 days following myocardial infarction?
I agree with Roxana. I think you should be careful, but yeah, I think you should. Don't think aspirin is that dangerous, so why not use it? Because we know that it is important to have it the first period, so why not use it at least 4 weeks?
Yeah, well, that's we'll see this in a moment on the second paper. What do you think with all this aspirin business?
So it's fascinating. I was listening carefully to Roxana, and it's great that Dr. Fuster is here as one of the world experts on thrombosis. I actually thought that it's sinful to stop aspirin anytime 6 months before, and now we are fighting literally over a few weeks.
Yeah.
So if you had picked 1 month as in your trial, that tells you that the gut instinct of investigators is you'd already come to a fine point. So does that extra 2 weeks dramatically change bleeding? You said 2 and 4.9%. So are we like getting into a kind of a trialomania?
No, you know what though? It's 2, but it was a year of dual antiplatelet therapies, and they watched these patients over that year period. Most of those events in the withdrawal arm happened very early, peri-procedurally, as you discussed.
Exactly.
So I think I'm not surprised that there was a dramatic decrease in bleeding because they were exposed for a longer period of time. You really should be withdrawing aspirin in high bleeding risk patients after a good period, 1 to 3 months of dual antiplatelet therapies.
I would say, as a general cardiologist in this discussion, 1 month sounds good to me, unless someone had a critical reason why you
You're
have to
talking about
stop.
the next paper.
Exactly.
Biykem, would you discontinue aspirin right away?
No.
All right, thank you.
Yes.
Okay, so let's go now into the next paper on aspirin. And let me see. This paper actually, is from the group at Cleveland. Excuse me, no. I'm sorry, this is the Nethercampton.
Yeah.
This second paper is, I think was Latin America.
Target, right?
Yeah, Italy, Padua.
Padua.
Yeah, the title is Early Discontinuation of Aspirin, again, after PCI, in low-risk acute myocardial infarction, the target first investigators. And this was published also in the New England Journal of Medicine, and Dr. Tarantini was the presenter. Well, basically, in this particular paper, what they do is exactly what we talk about, by they discontinue aspirin 1 month. Okay? We can go on and on and on, but the results were good, indeed. So it didn't hurt in terms of the events, and then the type of bleeding was a little bit less as expected in the group with monotherapy. So this means that, Biykem, this means that perhaps the way we see the future is that 1 month, before I ask Roxana, who has been into this for years, do you think 1 month is the time?
I think it's quite reasonable.
Good.
DABT for 1 month and then monotherapy subsequently.
What do you think, Roxana?
I think within a month, I often feel good about all of the totality of the evidence now with going to ticagrelor monotherapy. We don't have that much data on prasugrel monotherapy, but I don't believe there would be any difference. 1 month seems to be a great time. You really have to imagine that in that month, you're getting enough ticagrelor on board, and the things have settled down with the dual antiplatelet therapies. Let's withdraw, let the patient be on ticagrelor, and things will be great.
In your studies, you have been quite conservative, if I go back, isn't it?
Yes.
Because you started with 6 months.
3 months.
The-
In
the
Twilight,
first 3 months,
in
yeah.
Twilight, 3 months,
months,
of
yeah.
dual antiplatelet therapy, and then only event-free patients remember, this was the very first time we were withdrawing aspirin. Double-blind, placebo-controlled trial. We withdrew in event-free patients who were compliant with their antiplatelet therapies, and we showed 50% reduction in bleeding with absolutely no difference in 8,000 patients.
It was followed by a number of studies, not yours, with 6 months.
Multitudes of studies that did 3 months, 1 month, and they did particularly all the same.
Yeah. Well, anyway, it seems to me that it is reasonable to stop aspirin unless it's a high thrombogenic patient for whatever reason, to stop aspirin reasonably early, maybe 1 month. Okay? So this is an advantage.
In presence of a potent P2Y12 inhibitor,
yeah.
it doesn't work with clopidogrel.
It's a good point, actually. We are talking about when you say it doesn't work, is any data?
Yes, the STOP-DAPT investigators showed that in ACS patients, it was not non-inferior. In other words, more ischemic events
with clopidogrel.
With clopidogrel monotherapy,
yeah.
Which makes sense, right? There's some non-responsiveness there.
Yeah, understand it. Okay, so we have now the paper number 9, which is the ODYSSEY-HCM study, mavacamten in symptomatic non-obstructive hypertrophic cardiomyopathy by the group at Cleveland. Dr. Odyssey, I think, was the one who presented the study. Well, we know the story of mavacamten. In the sarcomere, you decrease contractility in obstructive cardiomyopathy, and it seems it's working, and I'm not going into the detail. Should it work in non-obstructive cardiomyopathy, which is about 40% of patients with hypertrophic cardiomyopathy? And I was thinking, at the beginning I thought this is nonsense, but then I thought maybe this sarcomeric inhibition may make the heart to be less contractile, you know. So it makes a little bit sense to do the study. So, and this is actually what they did. It's an interesting study. It was conducted as a phase 3 international double-blind, placebo-controlled clinical trial to determine whether mavacamten improves functional capacity and patient-reported health status among adults with asymptomatic non-obstructive cardiomyopathy. They started with 5 milligrams of mavacamten per day and adjusted to a maximum of 15 milligrams. And there was a group that treated with the drug and a group treated with placebo. And the follow-up was actually 1 year. Would they look at the primary endpoint, as I mentioned, first what happens biologically, change from baseline to in peak oxygen uptake. And second, the Kansas City cardiomyopathy score. So look at the functionally what happened. To make the long story short, actually what they found is no effect of the drug in patients with non-obstructive cardiomyopathy. We could go into the details, but this is basically what it was found. And is this surprising? Well, I don't think it's surprising, but I think it was worthwhile to test. But there was a problem in the study, and that is ejection fraction drop in 21% of the patients treated with mavacamten, less than 50%. And in 30% of the, in about a significant number, I think it was about 3%, the ejection fraction below 30%. So what I'm saying about this study, what I learned, at least personally, is that it doesn't work, but it can harm. So Gry, what do you think?
I agree.
Okay, that's a good answer. Biykem?
Fully agree. The patients were included if they had a gradient, LV outflow gradient up to 30 at baseline and 50 with provocation. They did have diastolic dysfunction and they did have symptoms. Their baseline KCCQ was low, their peak VO2 was low. This study tells us that cardiac myosin inhibitors, in essence, potentially can be harmful when you don't have the gradient. And I think it does also create questions about ongoing studies with HFpEF, because these agents are being tested in HFpEF with EF over 55, 60. I think this will need to be calibrated, especially with the concerns about the safety. 1 in 5 patients had a drop in their EF. There's intriguing findings in another publication that they dropped the NT-proBNP, they decreased the NT-proBNP, as well as overall the troponin. The diastolic dysfunction, because the contractile performance is coming down early on, may reflect some reduction in the filling pressures, but in the long run, with the decline in EF, I have a feeling they may reverse. So I think this is concerning.
Anyway, what do you think?
The drop in ejection fraction was disconcerting. My one other point, which I was going to ask the audience and the panel and yourself, Dr. Fuster, is, do you think there'd be some imaging studies where there are forms of hypertrophic cardiomyopathy where it's not classic outflow obstruction but mid-ventricular obstruction, which if it's left for long enough, other parts of the heart remodel. So we ablate ventricular tachycardia in the more apical regions. So you think there'd be more personalization and perhaps you'll select the drug. Thankfully now it's available.
Roxana, he's talking about personalized medicine.
Yeah, and I mean, it just shows you it's not one size fits all. And when you start to see this concern of we cannot be giving these agents across the board to everyone, and it seems to me, as you described so beautifully, that there is going to be a lot of personalized evaluation of these patients, and it's concerning. 1 in 5 is concerning.
It is concerning. Well, thank you very much. We have 5 minutes. Let's talk about 4 papers. So the answer is yes, no, yes, no. Is that right? BETAMI-DANB, I still remember, was 2020. Dr. Armstrong presented the Victoria study. These are patients with low ejection fraction that give this drug that also affects contractility, indeed, but in the opposite way. It increases contractility. Without going into any details, but I want to present what was presented in 2020, and there were about 5,000 patients. They gave the drug, and the results were actually 35% event rate with BETAMI-DANB versus 38% on placebo. I was not turned on, I have to say. This is a personal feeling, and but it was a big thing. These patients were treated properly, it seems, medically. And then it came the study that was presented in this meeting, the Victory study, and then the combination of both. Well, the combination of both, just to make the long story short, it shows the difference between 25.9% event rate in the group with placebo versus 27.9% in the group that is treated with the drug. What do you think? Are you excited?
Victor study, the new study, is intriguing because the primary endpoint, which was a combined endpoint of cardiovascular death and heart failure hospitalization, is not different. But death is, and sudden cardiac death was reduced. We've never seen this in heart failure trials ever before, that heart failure hospitalizations are not reduced, that the heart is not better for the hospitalizations, and sudden death is reduced. Never had this before. This is guanylate cyclase stimulator, and the intriguing question is there some stability in the microcirculation and arrhythmogenicity and or other factors, or is this
so you think the field should be pursued?
I think we need more data. I was asking Dr. Zanad, who presented, saying whether they have the ICD data, the shock data, and
to see what happened
to the MI stroke. Give us a story about how did the cardiovascular death go down, even though the heart failure events were not down.
Well,
so more questions than answers.
Fluke should not be ruled out.
Yeah, this could be a fluke.
This could be a statistical issue.
Yes, I totally agree.
Anyway, we'll continue to hear about this drug then.
More questions than answers, Dr. Fuster.
Okay, good. All right. The second is this resistant hypertension, the efficacy and safety of baxdrostat in uncontrolled and resistant hypertension. This is actually an aldosterone synthase inhibitor. And you know what I can say is that using this drug in patients with resistant hypertension, hypertension treated very well between 140 and 170 systolic pressure, they drop, the maximum drop is 15 millimeters of mercury. So here's my question. Is the drop of 15 millimeters of mercury in resistant high hypertension, it turns you on?
Well, first of all, I think this whole concept of aldosterone synthase inhibitors are, I think they're going to be life-changing for a lot of patients. Even 15 millimeters resistant hypertension, I think it's interesting. But it's no different than what we saw in renal denervation studies, about 15 millimeters of mercury. You still have to take a pill every day, but I also think the science behind this is even more interesting because it's not just all adrenal hypoplasia, but actually lakes of cells that are making, aldosterone and leading to this resistant hypertension. There is a lot more resistant hypertension than meets the eye, and these drugs could be life-changing, even with a 15 millimeter drop.
Well, what I thought is like anything, like in heart failure, we use 4 drugs, maybe will be renal denervation in one of these drugs, It will be one after the other with very little each of them. Well, the next paper is the uses in high triglyceride levels, TIMI 73B investigators paper, which they use a drug called olezarsen, and it's interesting that I talk about adherence. This is the type of subcutaneous injection once a month that goes to the liver. It blocks the RNA that synthesizes the problem of the triglyceride problem, and drops triglyceride levels by is reasonably significant. So again, I think what is interesting about this drug, this is why I'm presenting these papers, because are something intriguing. What is interesting is that the future of adherence is going to be not oral medicines, but it's going to be subcutaneous medicines going into the liver and blocking, like inclisiran twice a year, and here triglycerides is once a month. And finally, the REBOOT study, we found that in women, beta blockers actually had a problem with mortality. And I don't have any idea why, whether it's chance, but the results were quite significant. And the question is, why you think, Roxana, that giving beta blockers in women could be a problem following myocardial infarction when you have a normal ejection fraction?
Yeah, I mean, I think you also, the idea that we need to think about sex as a biological variable is really coming to fruition. We need to think about women biologically different in different stages of their lives. And we now saw the pregnancy guidelines that came out that actually downgraded the use of beta blockers in women from a class 1 in hypertension and low ejection fraction down to 2A. I think we're going to see more and more about differences in multitudes of drugs, so I'm not at all surprised by these results. I'm glad to see this.
It was interesting. Well, we are done. Frankly, this is great. Final question. Which one of these trials are most exciting to you, Shib?
I would say the atrial fibrillation studies. Because
Which one?
It's going to be surprisingly, I vote for the monitoring study because it's going to help us design better studies, because every patient
learn the prevalence.
Exactly. Every patient is going to monitor more. It's going to change every cardiologist's life.
Biykem.
Beta blockers post-MI practice changing.
Interesting. You?
Beta blockers.
And me too, beta blockers.
Okay. I'm very curious about your monitoring. But, I respect you. I mean, it may
It's going to make our life much harder.
Thank you. I do a lot of monitoring.
It may be. Well, look, this was fantastic. And thank you very much. We were in agreement in almost everything, which is always a problem. But at least we were able to discuss trials that have a lot of questions, the majority of them. Again, thank you very much again. And I will say to you, 10 plus, you will be invited again. Thank you.
Thank you so much.
Thank you all.
Dr. Fuster.
Thank you.